We're from Lodi Memorial Hospital. Lodi Memorial Hospital is a 214-bed not-for-profit community hospital in Lodi, California. I'm Valerie, Director of Utilization Management.
I'm Kathy, Patient Discharge Advocate.
I'm Kelly, Patient Discharge Advocate. Julie, Evidence-Based Practice Coordinator.
I'm Jamie, RN Case Manager.
And Erica, Transition Social Worker.
So our story started when administration looked at the problem that 18 to 20% of Medicare beneficiaries were readmitted, and the fact that we would be receiving decreased Medicare reimbursement because of that. They changed the strategic plan to include readmission prevention, and they developed a multidisciplinary task force. Our administration actually assigned managers and directors to the task force. I was tasked with leading the group, and we had to report back to management team every 2 months about our progress. We then applied for and received a grant for the BOOST program, and we chose that as our transition program. January of 2011, we sent a team of 12 for training. Our task force met religiously every 2 weeks, and we developed breakout groups to work on each part of the tools for our transition program.
We utilize a target assessment tool that helps us identify patients that are at high risk for readmission.
We created a Passport to Care form. This form goes home with the patient. It consolidates the discharge plan onto one sheet consisting of follow-up appointments and any agencies that will be following patient post-discharge.
We also implemented a new philosophy of education called Teach Back, which requires that patients speak back or show back what they've been taught to validate what they actually learned while they were here.
We've been making follow-up phone calls within 72 hours to our Medicare patients and also to patients that we've identified as high risk for readmission.
So in May of 2011, we rolled out a trial program for our transition program on one of our floors. It was a strong nursing case management effort, and we had a plan to roll it out to all our floors in fall of 2011. About a week before we were ready to present to management team, the nurse manager from the floor came to me and said, "We're not ready." So not being very fond of the idea of going back to management team and telling them we're not meeting our goals, I said, "What do you mean we're not ready?" She said, "Well, this needs to be sustainable. We need a strong foundation." So we had a conversation about what the roadblocks were preventing us from doing this. I said, "This thing has become a Medusa." And we were trying to think of a creative way to present it to our management team meeting. And we actually clipped on each one of the barriers to a snake. And I put it on her head. We pulled off each barrier. And by the time we were done, the team fully understood what we were facing. So just a few of the barriers. Our first barrier was culture change. And implementing a culture change in a hospital, like a transition program, is a big deal. You're talking about nursing changes and changes for every department. So culture change was its very own snake. Another barrier that we looked at that's its very own snake was medication reconciliation. So you know how difficult that can be on the front end, obtaining patient information, trying to determine what patients understand about their medication. And on the transition end, getting patients to understand what they need to take when they go home, and then who knows what happens with patient follow-through when they go to the pharmacy or go to their primary care physician's office. Another barrier that we had was lack of ownership. Who's really responsible for the process, the paperwork, the changes, the education that has to happen. It needs ongoing time commitment, and it needs a leader. We also noticed that our discharge process was not standardized. It was broken on the nursing end with patient education, and our case managers couldn't really focus on the clinical course of care because they were always tied up with difficult discharge details. So we revised our plan, and we reset our rollout date for January of 2012. In August of 2011, we implemented a transition social worker position.
As the transition social worker, I get to work with frequent flyers and also self-pay patients. And with a bulk of those, probably 3/4 of my patients being self-pay. But with the frequent flyers, one example of a person that I would really case manage would be a 52-year-old schizophrenic patient who had Medicare Medi-Cal lapsed. He was unable to problem solve and figure out how to get it back going, so he really began to frequent the ER. So it was my job to get in, and after about 40-45 phone calls and building trust with him, getting him to actually come in, assisting with getting his Medi-Cal going, and then assisting him with getting a new physician so that he had somebody he trusted in the community. And since that was done after about a 3-month process, you know, he's not been a frequent flyer anymore. So that's just one example of patients that I get to help.
In October of 2011, case managers were implemented in the emergency department. Part of the job is preventing readmissions on the front end. Other job duties include assisting patients to the appropriate level of care as needed, and also linking patients to community resources as appropriate.
So during our trial, the nursing management team uses as a time to standardize our education materials so that patients were receiving the same materials from home health, from our clinics, and from the hospitals. And they actually developed an education pathway for education so that they begin identifying patients' education needs on day 1, and then they specify what needs to be done on day 2 and day 3. We also use skills days so that the nurses learn about the education pathway and learn about teach-back. And nursing also standardized their shift reports to include a focus on high risk for readmissions.
In January of 2012, we revised our case management floor model. The case managers actually focus on clinical course of care, length of stay, and level of care.
As part of the revised floor model, in January 2012, we implemented the new discharge advocate position. I am not a nurse nor a social worker. My job is as patient discharge advocate is to establish strong patient and family contact. I follow patient from first day admission through discharge to anticipate any discharge needs and to ensure a safe and smooth discharge plan, to include identifying patients that are at high risk for readmission.
We've also revised our follow-up phone call process so that we reach more patients. We talk about their medications. Did they pick up their new prescriptions? Do they have a system in place if they are taking multiple medications? We talk about their follow-up appointments. So far, 99% of the patients we've reached have expressed their appreciation that Lodi Memorial Hospital continues to care for them even after they've returned home.
Externally, we've moved out into the community. We've taken a lot of the principles that we've discussed, and we've rolled them out to our skilled nursing facilities. We meet with them monthly in a cross-setting work group. We discuss communication barriers, and we try to standardize the patient care across the continuum. On a quarterly basis, we're meeting with our community partners. That includes our home health, assisted living. We're bringing everyone in to kind of talk about what we're working on and better ways to communicate and prevent readmissions.
We're also drilling down on our readmissions, beginning in the emergency department. The case managers look at them on the floor. We look at them from the community, from patients that have home health, and from the skilled nursing facilities. We identify readmissions that come from specific facilities, and then we meet with them to have a discussion about what could have been done better on our end and what could have been done better on their end to prevent the readmission.
And one topic that's been born out of those skilled nursing readmission meetings is the need for palliative care education. So we're really focusing on identifying those patients within the hospital, patients who have chronic disease processes who could benefit from having a meeting with our palliative care team meeting to really understand where they're at in their disease process and where to go from here. So we're doing post-CMAs classes, we're doing advanced directive classes, and we are just continuing to educate staff across the spectrum.
So we have many new processes, and we're working on standardizing and hardwiring our processes. Our recommendations to other hospitals that are considering implementing transition programs is to get strong administrative support if you can.
You'll need strong leadership, somebody to drive this and be the champion for change.
Really need to develop a multidisciplinary approach and create those relationships with all the departments and all the community providers, because it's going to take a village.
Physician education is of utmost importance.
And continue to build communication within your community.
But most of all, remember to think out of the box.
You'll need a strong commitment to your program.
So it's been a very busy 2 years for us, and like I said, we have a lot of new processes in place. We have, going forward, a lot of work to do to standardize processes and to hardwire them, but we're already starting to see positive changes in our readmission rate and in how patients are functioning in the community. Thank you.